Good afternoon. Hi, everyone. Welcome to our Prevention and Epidemiology Committee meeting. If you all outside slowly make your ways into the meeting room, you can continue enjoying your lunch while listening to us. So it's a great pleasure to open the session for today. We have a full and exciting agenda. All right, okay, I will continue. I think we did it 2 times, so I don't know if you want to.
But you can do it again.
Yeah. All right, but we'll go ahead and get started. So just before we start with our invited speaker, a few announcements. Our committee mission and goals, I'm not going to read through them, but you are all very aware what we are trying to achieve here, really, practice changing interventions, prevention trials in high-risk populations, in average-risk populations, screening studies with biomarker endpoints, and also to prevent secondary primary cancers or progression of disease from stage 0 or in situ disease, as well as behavioral modifications such as smoking cessation and implementation science is really our focus areas for our committee. I also want to remind Hope is at 30 now, and as you know, very vital for our organization and our committees, and very impactful for our trials, advocates, young investigators. So please think of them and consider donating. And here are some stories, inspirational stories and links related to the Hope Foundation at 30 years now, and they have a lovely booth outside, so if you want to visit them. So, and these are the upcoming funding opportunities that we discuss actually every month during our phone conferences. So, please, there are several options for not only early career, but also mid-career and any career investigators who are interested for our committee and related trials. So without further ado, Dr. Marian Neuhauser will take over from here.
Good afternoon, everyone, and welcome. It's my great pleasure to introduce our guest speaker today, Dr. Britton Trabert. Dr. Trabert is a reproductive and cancer epidemiologist and associate professor of obstetrics and gynecology at the University of Utah School of Medicine, adjunct in population health sciences at University of Utah School of Medicine, and a full member of the Cancer Control and Population Sciences program at the Huntsman Cancer Institute in Utah. Dr. Trabert received her MPH in epidemiology from the Rollins School of Public Health at Emory University, an MS in biostatistics from the University of Michigan, and a PhD in epidemiology from the University of Washington School of Public Health. Prior to joining the University of Utah and the Huntsman Cancer Institute, Dr. Trabert was an Earl Stademan tenure-track investigator in the Division of Cancer Epidemiology and Genetics at the National Cancer Institute. Dr. Trabert is actively involved in numerous consortia, including being co-chair of the Ovarian Cancer Cohort Consortium, and she also serves as co-chair of the Mentoring Committee for the Society for Epidemiologic Research. Dr. Trabert's research program addresses critical research questions related to the prevention of gynecologic cancers and integrates pharmacoepidemiology, reproductive epidemiology, and molecular epidemiology to understand cancer risk, etiologic heterogeneity, and progression. She's PI of a DoD Investigator-Initiated Research Award in the Ovarian Cancer Research Program to evaluate the association between frequent aspirin use and ovarian cancer risk, and has received expanded funding to study other common medications, including statins, and the role in ovarian cancer prevention. And if you've seen the Cancer Letter recently and other publications. Her work has recently been highlighted there as a way that drugs can be repurposed for cancer prevention. So we're delighted to have her. She'll be presenting remotely. And as you can see, she started to share her screen. So at this time, I'll turn it over to Dr. Traber and welcome.
Thank you. So I'm glad to hear you can see my screen. Can you hear me okay?
Yes, we can hear you.
Perfect. Great. So thank you for that nice introduction and the invitation to speak today. I am going to talk about some research related to commonly used medications and their role in gynecologic cancer prevention. And I'm going to focus on both ovarian and endometrial cancers for my talk. So in terms of disclosures, I have none. I do not plan on talking about off-label use, but I am going to talk about how aspirin, statins, and other common medications play a role in the etiology or prevention of endometrial and ovarian cancers. I'm going to start with oral contraceptive usage. And as you all know, oral contraceptive usage prevents gynecologic cancers. We see a 30 to 50% reduction in both ovarian and endometrial cancer risk with 5 or more years of oral contraceptive use. And this risk reduction really persists 30 plus years after cessation of last use. About approximately 20% of individuals have used OCs. However, we've been able to demonstrate using NHANES and National Survey of Family Growth data that this use is really decreasing over time. And some of that usage seems to be replaced by hormonal IUDs. And we know that hormonal IUDs are likely to prevent endometrial cancer. And I think the question still remains on their role in ovarian cancer prevention. We were able to look at this ovarian and endometrial cancer prevention. So what I have here I'm showing ovarian cancer risk and endometrial cancer risk. So the marker is the point estimate with the 95% confidence interval. And the first line here shows us the risk reduction for all women. And then we looked at whether or not the association was kind of consistent across other common risk factors. And for ovarian cancer, we see a very consistent reduction in ovarian cancer risk across common cancer risk factors. And I think importantly for endometrial cancer, we really see the largest risk reductions in those groups who are at highest risk of endometrial cancer. So with BMIs of 30 plus, or who are physically inactive. And so this was really kind of using some of the large prospective cohort data that was out there to answer public health relevant questions about prevention for these cancers and potentially targeting high-risk groups. I think you also all know the kind of differential role in terms of menopausal hormone therapy, where we know that unopposed estrogen increases risk of endometrial cancer. I mean, that story is 50 plus years old. And then ovarian cancers as well. And that we see with continuous estrogen plus progestin that this provides kind of protection or prevention for endometrial cancer, and emerging data when you kind of carefully evaluate the population that most likely is to use continuous estrogen plus progestin. So this is women who have not had a hysterectomy, that we're also seeing modest reductions in ovarian cancer risk in that population. And then to kind of segue in terms of anti-inflammatory medication or thinking about aspirin use and cardiovascular disease prevention, I've been able to show through research that regular aspirin use decreases the risk of ovarian and endometrial cancers. I think the ovarian cancer work that I've done has kind of been the more publicized work, in that we're seeing a 13% reduction in ovarian cancer risk. And then for endometrial cancer, the overall association is more modest. We see a 7% reduction in risk, but those, again, associations have really been most pronounced among individuals with higher BMIs. I think when we're talking about these common medications, we really have to think about side effects, especially when we think about regular aspirin use. And so those are, and then really thinking about kind of balancing the risk benefit in terms of prevention and thinking about really what populations we need to be targeting for prevention. prevention. So side effects, I think the most severe and concerning in terms of kind of widespread aspirin use is the increased risk of GI bleeding events and stroke. And so I'm going to show a couple of forest plots here to demonstrate the endometrial cancer risk. So, to demonstrate both gynecologic cancer risks. I'm starting here with endometrial cancer. So again, I have the kind of forest plot that shows the risk estimate and 95% confidence interval. And what I really want to emphasize for endometrial cancer is, again, this regular aspirin use, the reduction in endometrial cancer risk is really among the population that we would target that is at highest risk. So those with higher BMIs. And then the risk reduction is kind of similar for the other common reproductive factors that we think about in terms of risk, and then also kind of consistent across the kind of dualistic subtypes of endometrial cancer. For ovarian cancer, we again were interested in whether or not the aspirin was able to prevent ovarian cancer among individuals with ovarian cancer risk factors. And so with the exception of a positive personal history of endometriosis, we see that the point estimate really suggests reduction in risk across all of these strata of ovarian cancer risk factors. And when we looked at a kind of cumulative score, having 2 or more risk factors was associated with almost aspirin use among individuals with 2 or more risk factors was associated with an almost 20% reduction in ovarian cancer risk. So this was a combination of both case control and cohort study data that showed very consistent associations across the study designs and also across the different histotypes of ovarian cancer. And using the prospective data, we were actually able to calculate the number needed to treat to prevent 1 ovarian cancer if the prevention approach took treating all women, and so that's about 1,700 individuals. But if we focus on a high-risk group using the epidemiologic risk factors, we can cut that number in half to 970. And so I think this was a really important aspect of this research, in that we could show that targeting a high-risk group is definitely going to be more beneficial in terms of fewer number needed to treat to prevent an ovarian cancer. And so I know the kind of burning question is, what about statins? And so I'm going to kind of spend the rest of my talk focusing on the research that exists about statins and gynecologic cancer prevention. In terms of a history, I mean, statins were approved for use in the US in 1987. That was really among individuals who had had a cardiovascular disease event, and then it was really meant to prevent future events within those populations. It wasn't until the early 2000s where statins became available as generics, and they started to increase for kind of reasons other than cardiovascular disease among cardiovascular disease patients for like secondary prevention. In 2013, then guidelines were expanded to really allow this low to moderate use for primary prevention of cardiovascular disease events among individuals as young as 40, and really kind of focused on this high cholesterol and high calculated clinical risk of cardiovascular disease. And so then that really led to widespread usage, and then also widespread kind of amplification of the side effects in the media. And so then there has been some revision in terms of cholesterol guidelines, but these medications are still prescribed widely for individuals with high cholesterol levels in terms of thinking about primary cardiovascular disease prevention. And so when we look at kind of patterns of use over time, this is among the CVD patients. They're prescribed at about more than 80%, and that's high intensity statins, and their use has really remained constant since the early part of this century on. But we've seen this kind of uptick in low to moderate intensity statin use, as well as in statin initiators, so people who are taking statins for their first time. And that really kind of follows this 2013 kind of change in practice, and we're seeing that really play out in a number of data sources. And so when we talk about statins, there are really two predominant, there are two primary classes. There are the lipophilic statins and the hydrophilic statins. The lipophilic statins are much more commonly used, so they're about 75% of prescriptions in the US. where the hydrophilic statins are about 25% of prescriptions. There are many benefits of statin use, both in terms of primary and secondary cardiovascular prevention. And the indications for use include both cardiovascular disease and then related comorbidities. So dyslipidemia, like we mentioned, cholesterol levels are the primary treatment for primary indication for treatment, hypertension, heart disease, and type 2 diabetes. And really their functional mechanism is that they block cholesterol production. They're kind of magic little pills, many people think. And so the mevalonate pathway is really the pathway that they're blocking. And they work in this step between HMG-CoA to mevalonate. And the mevalonate pathway is a very highly conserved pathway in the human body. It plays a key role in many cellular processes. And it's important precursors of bile acids, lipoproteins, and steroid hormones, importantly, because it's cholesterol is the kind of metabolite that basically kicks off all of the steroid hormone metabolism. And so there are a lot of effects of this pathway that we can see in the human body, and block the statin's ability to block this pathway really alters many things. It decreases serotonin levels, it decreases glucose uptake, it decreases hormone secretion. So there are many kind of possible mechanisms through which statin use could have effects on cancer incidence. There are numerous papers in terms of describing the potential cancer-related mechanisms of statins. These papers, many of them focus on statin tumor interactions, so at the tumor microenvironment level. But I think in terms of if we're thinking about kind of early interception or prevention of gynecologic cancers, I think statin's ability to reduce systemic inflammation and also alter potential steroid hormone levels are other really important and relevant mechanisms we need to consider when we're thinking about gynecologic cancer prevention. And so the mechanisms and effects related to gynecologic cancer that we see in the literature is statins reduce CRP levels. And CRP levels have been shown to be correlated strongly with like doubling of risk for both ovarian and endometrial cancers. Statin use is also correlated with increased fat and calorie intake and potentially higher BMIs. And again, I use correlated here because it's treatment for high cholesterol, but it's also I think we kind of don't know necessarily the directionality of the association in terms of both increased fat and calorie intake and BMI. And so there's a lot of kind of studies out there that are cross-sectional in nature that have characterized these associations. But in terms of kind of intervention and whether there are dietary changes or loss of BMI with individuals on statins is more of a question, because they're definitely not your kind of traditionally thought of weight loss medications. There's really limited data on whether statins reduce circulating hormone levels to a level that could influence specifically endometrial cancer risk. But I think kind of the concern is then the kind of increase in BMI, at least in postmenopausal women, is associated with a higher estrogen environment. So really kind of teasing out that those associations would require more detailed and kind of comprehensive data than kind of the existing stuff that we have in our cohorts and case control studies. I think the kind of biggest kind of hurdle and challenge in terms of thinking about statins and long-term outcomes really is that adherence to statin prescriptions is relatively low. So the estimates from AHRQ is that 33 to 50% of initial prescriptions aren't filled. And then of those that are filled, many stop taking within 6 months, and the kind of attributing factors to stopping statin use is kind of lack of tangible benefits, and so short-term changes in cholesterol levels or other kind of perceived outcomes, cost, and then side effects. And so in about 1 to 10% of users, and it kind of varies on the population, there's kind of substantial muscle pain or muscle fatigue that is noted that basically leads to people stopping statin use. In terms of severe risk factors, I mean, they're less frequent than the bleeding risks with aspirin. So the one kind of most severe side effect of statin use is rhabdomyolysis, which is less than 1% of users. And it's, it's kind of what is talked about in terms of balancing risk benefit of statin use. But it's really quite low comparatively. We have seen a kind of surgence of the prevalence of statin use. And so this is NHANES data where we can show from the early 2000s to 2018, which was the most recent cycle when I pulled this data, that statin use among US women 40 plus has more than doubled. So from 11% to almost 25% in the 2017 to 2018 survey cycle. These are the age-specific trends in statin use and statin incident and cancer incidence. And so we see here kind of this steady climb in terms of prevalence of statin use, which you would expect. And then these are really the endometrial in orange and ovarian cancer in teal, the kind of age-specific incidence of ovarian and endometrial cancer. And so if we're thinking about kind of prevention, we really want to see kind of an increased use in this kind of in the 45 to 55 age range. So that would kind of precede or kind of fit into the space of thinking about it being relevant for gynecologic cancer prevention. And I think as we kind of update these data with other NHANES survey cycles, we are seeing upticks in usage in those kind of target populations that you would want to think about for cancer prevention. There have been numerous meta-analyses of ovarian and endometrial cancer. I really just kind of have summarized the different summary relative risks by publication year. For ovarian cancer, the story has kind of, as we've added more data, attenuated slightly and kind of become maybe a little less pronounced as we saw kind of initially, and some of that could be due to publication bias. I think for endometrial cancer, the associations have kind of gone in the other direction, and as we've added more data, the association has actually strengthened. I think the kind of biggest criticism of these meta-analyses and kind of their inherent difficulty in trying to address these questions is that the study populations and then the summary estimates are consistently heterogeneous. And these studies have really identified the need for larger, well-designed studies with updated medication use assessments to really be able to evaluate this association appropriately for gynecologic cancers, and then also to evaluate associations by relevant subgroups that can really inform cancer prevention. So statin class, cancer histotype, indication for use. And so in terms of really thinking about kind of what is needed in this space and thinking about the epidemiology of ovarian and endometrial cancers and kind of the epidemiology of statin use, I think we need to make sure that future studies that evaluate these associations really carefully control for confounding by age, race, ethnicity, BMI, current smoking as relevant, and then also thinking about aspirin use, and then both OC use and parity in terms of ovarian cancer and endometrial cancer, because we see differences in kind of statin use patterns, and we know that these are factors associated with both gynecologic cancers. And so I think there's a real need to carefully control for confounding. I think we also have to really consider as an epidemiologic community confounding by indication. So really the reason for the statin prescription. Those really include thinking about indications for use. So cardiovascular disease and dyslipidemia. And then also thinking about kind of the time-dependent nature of kind of the usage of statins. So when they were primary treatment for cardiovascular disease events versus prevention of cardiovascular disease. Both dyslipidemia and type 2 diabetes are associated with endometrial and ovarian cancer outcomes. And so in addition to kind of confounding by indication, they also kind of qualify as confounders in the traditional definition. And so our studies need to kind of carefully account for these. I think we also really want to think about, like we have for the OCs and aspirin use, thinking about how the associations are stratified by other cancer risk factors. So BMI being an important one. I think menopausal status and/or menopausal hormone therapy use are really important. So oral hormone therapy use increases CRP levels by a first pass hepatic effect. Statins influence CRP levels independent of lowering lipids. Statins and oral and hormone therapies have been shown to attenuate that increase in CRP levels due to hormone therapy. And so there's definitely some kind of molecular interaction that we also want to be thinking about when we're trying to understand the ability of statins to maybe prevent gynecologic cancers. There's also some really nice literature from the Mendelian randomization studies that really provides support for the plausibility of these the ability of statins to prevent ovarian cancer, and ovarian and endometrial cancer. Sorry. There's a study that has shown that increased cancer risk, that there's increased endometrial cancer risk with genetically predicted lipids, and then that genetically proxied HMG-CoH reductase inhibition, basically kind of equivalent to a 1 millimole per liter reduction in LDL cholesterol, was associated with a reduction in ovarian cancer, both overall and among a high genetic risk population. Interestingly, the association of genetically predicted LDL was not associated with ovarian cancer, but that doesn't kind of rule out these other MR studies and really kind of providing plausible support for the ability of statins to prevent gynecologic cancers. And so when we really think about this, we need to develop the kind of data to demonstrate that the associations exist, and that they really exist in terms of the higher risk subpopulation, so we could do some targeted prevention and decrease the number needed to treat. But we also have to really think about balancing risks and benefits. And in kind of thinking about that, it's unlikely that for gynecologic cancer prevention that they would be recommended for the general population. And so that's where I think that it's really important to kind of pool resources and be able to really address the public health motivated questions of identifying the subgroups where statins would be most beneficial for prevention of gynecologic cancers. So really kind of thinking about high genetic risk and/or multiple epidemiologic risk factors, as we've done with aspirin use. We definitely need more research in this area. And as I mentioned, I think these future studies need to carefully consider the relevant time period of exposure, and of really developing kind of those exposure models from 2013 on, when statins were really prescribed for primary prevention rather than treatment of cardiovascular disease, is going to be important. We have to consider confounding effect modification, and then also, like I have mentioned numerous times, evaluate associations for relevant subgroups. As I was mentioned, I had an active DoD grant to evaluate aspirin, and I've been able to secure funding to expand on that to really address. So the expanded funding, which started last month, is going to be utilizing the Ovarian Cancer Cohort Consortium to address whether the Aspirin Ovarian Cancer Association is kind of consistent across use of other common prescription medications. So in that, I'm looking at statins, bisphosphonates, and hormone therapy. But then our second aim is to look at whether or not mevalonate pathway modifiers, so both statins and/or bisphosphonates, could be used in ovarian cancer prevention, and really thinking about that kind of targeting of the high-risk group, and then to try and understand some of statins' influence on the ovarian cancer tumor microenvironment. And so with that, I want to say thank you. I want to acknowledge that my research, everything that I presented and the research that I do couldn't be done without a great team. And so I would like to kind of acknowledge the study participants, co-authors and mentors, and then the great group of fellows that I have worked with and research analysts that I've worked with over time. This is my current research group, and my funding is listed across the top, and I'm happy to take questions.
Thank you so much, Dr. Trabert. And for those in the room, please come to the microphones in the center of the room for questions. And for anyone who's online who has questions, and we have 38 people online, please put your questions in the chat and we will address those. I'll start with a question while people are making their way to the microphones or typing their questions. Can you talk a little bit about how we think about reconciling observational and trial data? So when you were talking about the Esprit or the aspirin data and showing those results, it made me think of the Esprit trial. And can you tell us some ways we can think about that in terms of how we might move forward for a trial on repurposing some of these medications you discussed?
Sure. So I think I cut my internet connection cut out at the front end of the question, but the kind of general question is really what we need to demonstrate in terms of the prospective data to really inform the trials that would be done to repurpose statins for ovarian or endometrial cancer prevention, right? Did I capture the gist of that? Yeah.
Yes.
Yeah. I think the biggest piece is going to be really showing that the ability of statins to prevent these cancers are among those that we can identify that are at highest risk. And so for the ovarian cancer work, I didn't present on our evaluation using a polygenic score, but I think the risk factor, the epi risk factors show just as much kind of promise and are probably more clinically available in terms of identifying that. And so really, and the factors that I used in the epi risk score were family history of ovarian or breast cancer, personal history of endometriosis, tubal ligation, so Paris versus nulliparous, and then 5 or more years of OC use. And the individuals that had the risk factor component of that, so nulliparous hadn't used OCs for 5 years. If you add up a single point for each of those and having 2 or more of any of those risk factors, we identified that aspirin was associated with a 20% reduction. And so I think the same is going to need to be recapitulated for statin use to really identify that we can kind of target those higher risk populations and decrease the number of individuals that kind of needed to be treated to prevent a cancer. And so for endometrial cancer, I think we're going to need to demonstrate the association among individuals with higher BMI or, I think in terms of endometrial cancer, we could also think about the possible scenario of trying to see how statins potentially influence EIN being a precursor for endometrial cancer, and kind of thinking of, interception even earlier, or kind of measuring outcomes at an earlier stage than maybe overt cancer.
Thank you. And we have a question here in the room. Melinda Irwin, go right ahead.
Hi, really important presentation. Thank you for that. I know my question goes a little bit beyond your perhaps scope of work, but given so many women with ovarian cancer diagnosed at a late stage of disease, are you aware of the associations between statin use and ovarian cancer recurrence or mortality?
I get this question a lot. I should know this data better off the kind of top of my head, but no, I don't think I'm not aware of kind of compelling evidence, but I think much more research needs to be done in terms of understanding both the ability to prevent incidence and then also to prevent recurrence. And so I haven't seen kind of good data in that space. But admit I have not been looking hard. So I'm definitely not the right person to answer that question. Thank you.
Okay, I think we have one more question coming to the podium or coming to the microphone, excuse me.
Yeah, thank you so much. I thought that was a wonderful talk. I was just curious whether in assessing the benefit of contraceptives and protecting women from ovarian and endometrial cancer, if you observed any risk of other cancers. I'm a breast oncologist, and so in particular was curious about breast cancer risk.
Yeah, and so there is definitely a small increased risk of breast cancer with the kind of traditional oral contraceptives. That the kind of risk window though is kind of early initiation, and so the long-term users aren't really at as high a risk, and that then risk basically kind of diminishes with cessation of use. Whereas we see a longer term kind of prevention of ovarian cancer and endometrial cancer 30 plus years past use. And so, yeah, I mean, with all of the medications, we have to balance risk benefit. The EPT hormone therapy associations, I think we also have to think about there's increased breast cancer risk with oral progestins, and so there's no kind of smoking gun in terms of the perfect medication that doesn't increase risk of other potential outcomes and also prevent ovarian and endometrial cancer, unfortunately. Yeah, great point.
Just to follow up, I was just curious about like the IUD and whether that seemed to be different. I know that there's like limited data, but some maybe suggesting it could be protective even against breast cancer risk. So I was curious if you observed that at all.
Sorry, can you repeat that question?
So with the IUD in particular, I think there's questions around like systemic absorption of the hormones, and then because that may be more limited, whether the IUD really does pose the same risk conferred by oral contraceptives, and whether it may, in terms of breast cancer, whether
you're talking about protective. The hormonal levonorgestrel progestin-based IUDs. I don't think there's as big of an increased risk for breast cancer, but again, I'm not. I think that the data is limited in that those are a kind of more recent. They've grown in terms of usage, in terms of popularity, to really be able to understand that question. And so I think we will learn the kind of clear answer to that in kind of like the next 5 to 10 years. But we know they're great for the endometrium, right? And I think the verdict is still out on whether or not they will provide prevention of ovarian cancer. But yeah, I think we also don't, I think there's wide variability in the studies that have been done on limited numbers in terms of breast cancer. So I don't have a good answer for that either.
Thank you. There's a couple of messages in the chat.
Yeah, it looks like they're providing some, which I think are great. There's a WHO study that showed breast cancer was diagnosed in earlier stage in patients who took statins. So kind of connecting the dots there in terms of whether statins could potentially prevent breast cancer or be maybe better for all of the female cancers.
And Dr. Arun has a question.
Sure.
Hi, Despanu. Thank you so much for the lovely presentation. I was thinking, because of all of the confounding factors where you need to, correct for the underlying disease and all of the associated other risk factors and all of the medications, these patients, the aspirins, other NSAIDs, and other maybe interventions that reduce inflammation, and when you have to correct for these confounding factors, it ends up being a very large study. Is there you think, practical benefit to do a smaller surrogate endpoint study in women who don't have these risk factors? So who are not obese, who don't have a very high BMI, who don't have diabetes, but maybe they have a family history of gynecological cancers, and a more homogeneous but smaller cohort with kind of one or two precise biomarkers. Would that help a little bit to move the needle forward?
I don't know what those biomarkers or early endpoints would be for ovarian cancer. I mean, we've tried to do some studies where we think about Ki-67 in the fallopian tubes for OC use, but and trying to understand mechanisms there, but finding a patient population to enroll to be able to sample fallopian tubes is, I mean, we've discovered is near impossible. I think EIN for endometrial cancer and thinking in that context could help us. And I think, again, maybe the endometrium is a little easier to sample in terms of earlier. But again, it's like, I guess I'm reluctant in some sense to kind of subject a patient population to sampling for that type of, I mean, I think it's useful, but I guess I wonder what, and maybe that's the pessimist in me. I'm not sure we have good markers of intermediate effects that would be useful. And if they're not direct, and if statins aren't having a direct effect on the tissue, but are instead influencing hormone levels or inflammation, either locally or systemically, you're not necessarily going to capture that in that kind of intermediate endpoint population. And so I think it's a great idea. I guess I just haven't necessarily seen kind of good ways to go about that. But that it may also be my limited scope of kind of experience in those shorter term studies.
Thank you. Okay, I'm not seeing any more questions, so we can close out this. And again, thank you, Dr. Traber, for joining us.
Yeah, thanks so much for having me. This has been a lot of fun. Bye.
All right, now we are moving on, and I'm inviting Cheryl Jernigan to give us patient advocate updates, and she will be joining us virtually. And I will be forwarding the slides, Cheryl, for you. So when you tell me click or next, I'll do my best.
Thank you. And I'll do my best to be able to talk. I have a bad head and sinus cold, so that's why I'm not able to join you today. And I really wish I could be there. I want to thank you for the opportunity to share what your PAC has been up to. Next. At this meeting, we officially welcomed our new PAC co-chairs, and they are Anne Marie.
Yeah.
Mercurio and Barbara Segarra, and I believe they are both in the audience. So if you guys are still there, would you please stand up?
Hey, here they are. They are standing.
Yay. Anne Marie is a member of SWOG's Digital Engagement Committee, and she is a survivor of lobular breast cancer and was her late mother's primary caregiver throughout her 8-year treatment for metastatic breast cancer. And Barbara serves on our SWOG's Cancer Care Delivery Committee. She is a 2-time survivor of breast cancer and very passionate about addressing minority health disparities. Yesterday at the PAC, we had an engaging discussion with our SWOG leaders, Dr. Blanke, Don Hirschman, and Don Dizon. And they stress PAC's mission critical role is to assure that SWOG's research is patient-centered, and that means patient-centered from patients and communities' points of view. They also emphasize that our involvement is not just a checkbox in the triage process, but that we need to be involved and speak out on behalf of patients and communities from the beginning of the study development process, even way before we get to triage. So as a quick refresher of who PAC is, next. Okay, there it goes. All of our members are survivors and or co-survivors. We all experts in and we are the patient voice. Our expertise is gained only by living with cancer 24 hours a day, 7 days a week. And we have 2 types of patient advocates. First, we have patient research advocates who have extensive experience working with researchers and in research, and community patient advocates who bring us fresh frontline eye gained only from living or working in the communities they represent. They offer a unique perspective and expertise on issues affecting whether the people from their community could benefit or would like to even participate in a clinical trial. Together, we are striving to make sure that every SWOG trial is PC and PCO. That means patient-centered with patient-centered outcomes that matter to patients and communities. Next. Yesterday, we focused our involvement in the clinical trial development process and began to being laser focused on optimizing accruals and retention. Next, this graphic is one that you should be very familiar with. It outlines how research advocates are to be involved throughout the clinical trial development process. And throughout this process, we will be zeroing in on issues affecting and ways to enhance accruals and retention. As needed, community advocates are here to advise us on perspectives of their respective communities, and our committee can learn from them in 3 different ways today. We can think of, when we think a project would benefit from gaining perspectives from a particular community, we will invite the appropriate advocate to join our discussions. Second, we will invite them to, or we could invite them to provide a TED Talk of sorts at one of our meetings. For instance, on issues related to prevention in their community, like the young survivor community. Third, today you can attend the networking event with our community advocates at 5 p.m. today, and it's in the West Tower. Next, when advocates work on a concept for a study, 2 biggies usually come to the forefront: impact and representativeness. What impact will it have? How will this trial make a difference in how people feel, function, or survive? How will it make a meaningful difference in patient care and outcomes? Will the outcomes be important to patients and communities? What is the impact on the quality of life concerns? Can it be measured from a patient perspective? Next, how representative or inclusive will it be? This includes the language we used. Yesterday, SWOG's leadership urged PAC members to assure inclusive language is used in the informed consent, the protocol, and even in capsule presentations. Inclusive language is respectful of patients and communities, compassionate, and doesn't blame or label the patient. Other key issues we'll be looking at in terms of inclusiveness are demographics of the proposed study population and how well accrual goals reflect this demographic, whether there are any barriers to participation for patients or subgroups of patients. What are the inclusion and exclusion criteria and how could they impact participation, and could they be broadened? What aspects of this trial design might attract patients or be of concern to patients and families or particular communities? And finally, does this trial's design minimize the burdens on participants? Next, participant burdens affect both accrual and retention. The main questions we zero in on are: what are participants required to do for the trial? Can it be minimized? Or another way to look at this could be, how are we encouraging or facilitating their participation and making it easier for them, less of a burden? What are the added costs to participants? Can they be reduced? How does this trial balance the risk, benefits, and burdens of the patient and or the caregiver? Next, as we move forward in the trial development process, transparency and communication concerns also become paramount. Looking at the informed consent, as I mentioned already, is the language inclusive? What process is being used to assure a truly informed consent is really being achieved, especially for underserved or marginalized communities? How easy is the informed consent document to read and understand for all possible participants? And when the study is done, how are we planning to share the study results with participants and communities? I'm looking forward to working with you as we tackle these questions in our committee's studies. Lastly, I want to share a recent publication that I have been involved in. It's been a labor of love, and now I know not only have sympathy, but deep empathy for all of you who have been working on or currently working on getting an article published. Next, in 2016, the University of Kansas Cancer Center launched a unique initiative to infuse greater community and patient engagement into all aspects of the Cancer Center's research. Pivot, or patient and investigator voices organizing together, has the strong, visible support and very active support of the Cancer Center's leadership, starting with our center's director. They walk the talk. This patient-led initiative has grown into an invaluable resource for our researchers and an energizing resource for those surviving and co-surviving cancer. Today, we have over 160 members from across our service area, and our research advocates come from a variety of cancer experiences with many cancer types and are diverse in race, ethnicity, age, gender, urban, rural residents, experience with healthcare, and education. Our advocates are trained and coached in working with researchers. Based on the numerous requests we were getting from other research centers, this article was written as a roadmap to engagement that could be replicated or even adapted and adopted at other cancer research centers. The article is hot linked in this slide, and Patricia will be sending a link to this following this meeting. In designing studies for SWOG, some of my cancer center's researchers have reached out and involved Pivot in the process. One of them, Jill Hamilton Reeves, is now the lead researcher on Pivot's core team, and a couple others you might know are Jamie Myers and Andy Godwin. Next. And finally, I want to thank you all for all the stuff you continue to do to help patients and communities feel, function, and survive better, and would be glad to take any questions or comments or thoughts you might have. Thank you.
Thank you, Cheryl, so much. If we can take questions now for Cheryl. Looks like we have no questions. Cheryl, thank you so much. And we wish that you'll get better very soon. And next time we'll see you in person.
I thank you. And I look forward to being with you in person next time. And don't forget about the networking event at 5 o'clock in the West Tower.
All right. Thank you.
Okay, our next presentation is also going to be done virtually. Dr. Craig Nichols is going to give us an update on S1823. And this is co-led by he and Dr. Lucia Nappi. And for those of you who don't know, Dr. Nappi is an emerging, superstar in this area. This study had augmented funding from an R37 that was scored very, very well on the first try as an early career investigator. So she was awarded that R37. She also has additional funding from the DoD and has received numerous awards and accolades for this work. And I will also mention that this is the most rapidly accruing study I have ever seen anywhere. It's doing really well. So I think that indicates that there's a lot of patient interest for this study, for this surveillance study, as well as the wonderful support from the SWOG operations team and the sites who can enroll these patients. So I'm going to turn it over to Dr. Nichols now.
Thank you.
And you'll just need to say, next slide, because we'll control the slides from here.
Okay, could you put up the title slide? Okay, thank you. First of all, thanks for the opportunity to provide this update for S1823, and I will amend that to add CCTG GCC 01, which is the Canadian version of this through the Canadian Clinical Trials Group. I have no disclosures relevant to this presentation. Next. As it was outlined, Lucia Nappi usually gives these updates. She is currently in Istanbul talking about this, so you're stuck with me. Hopefully this is slightly familiar, but I'll just hit the highlights. MicroRNAs are typically non-coding RNAs that regulate oncogenes and oncosuppressor transcription. In the case of 371, the microRNA of interest for this study It is a regulator of embryonic development, which makes sense because germ cell tumors are basically a corrupted embryo, and it's named for a lot of the embryonic and placental anatomy. And the only false positive, or the only positive in normal human biology that we know of naturally is normal pregnancy. And that typically is not a confounder for us, since virtually all our patients in this particular trial are male. So that makes it quite handy. Next slide. This is considered maybe an ideal biomarker in that it is stable in serum or plasma. It is detectable through a simple blood draw and relatively straightforward RT-PCR. And the cost of the test is the research cost, we don't know what it would be commercially, is around $60 per sample, which puts it in range of other blood tests for sure. Next slide. Two prospective studies, one of which is ours, help define the current excitement and the basis for S1823. This one was published in JCO along with a large German trial looking at serum microRNA 371 in the pre and post orchiectomy setting. Ours was across the full spectrum of germ cell tumors, so it was a little more representative of the disease as a whole. Next slide. The upshot of this, our study and the Diekman study, was that microRNA had extraordinary specificity for detection of active germ cell cancer and very good sensitivity. In our study and several other large studies, there have been no false positives, and the false negatives are relatively uncommon. The other outstanding feature about this, that microRNA expression analysis is as a single test more accurate than combined CT scanning and traditional germ cell tumor markers, LDH, beta HCG, and alpha fetoprotein combined, and is obviously non-invasive, relatively cost-effective. And those characteristics are outline why both we and the world are extremely keen on bringing this to bringing along clinical development. And S1823 CCTG-01 is the lead trial in the world in adults with this disease, and the one that's going to rapidly be analyzed and hopefully remake the evaluation and assessment of germ cell tumor patients. Next slide. So this again outlines why we're doing this, and it checks all the boxes as an ideal biomarker. Cost, highly specific, highly sensitive, very easily available technology and methodologies, And results have been consistent across pretty much all the studies in the world. Next slide. So the top part of this pyramid is not exactly where we're at yet, but that is the ultimate goal, is to identify and define the clinical utility of this liquid biomarker in germ cell tumors. And that's the raison d'etre for S1823. Next slide. And in S1823, we kept it as simple as possible. And basically, we're asking the question is, can microRNA 371 predict or anticipate tumor relapse in patients with clinical stage 1 and 2A germ cell tumor? And in that question, we should be able to answer whether it can predict it, and can it predict it sooner than currently available clinical assessments such as CT or MR or traditional blood markers. Next slide. Again, it's a very simple study. You get a baseline sample submitted, and along the way, you get serial blood markers along with your regular clinical assessments, whatever they are doing, CT scans, blood markers, and then you either relapse or don't relapse. And we measure the serum microRNA 371 prior to any treatment of a relapse, so we can then predict or correlate the microRNA findings with the clinical results. Next slide. Next slide. We've completed the high-risk arm, and that's been closed for more than a year now. But the primary endpoint is in the low and moderate risk arm, and that is coming up on interim analysis. Next slide. Next slide. This trial was designed specifically with the idea that while we were very interested in the translational endpoint, we realized that to answer the translational endpoint, we would be creating a very rich and unique data set of clinical annotation for the samples that could be used for many secondary use of data projects. This trial is unique in that it depends somewhat on case report forms, but we also have require submission of source documentation. So pathology reports, imaging reports, blood marker reports, and so that creates a robust set of clinical annotation that can be mined for a variety of purposes, and we're just beginning to do that now. Since the primary, these are separate from the primary endpoint, we can start these secondary use of data activities now. We had a trials in progress presentation at the ASCO annual meeting in this May. We just submitted an ASCO GU abstract for the clinical stage 1 clinical data, and we have 2 more planned for ASCO annual meeting in 24 with stage 2 and distant disease clinical parameters and selection of treatments. And so those are, we're already starting to launch these secondary use of data projects. And I noted that Katie Arnold's in the audience, and she and her team have been invaluable in helping us assemble these secondary use of data projects. Next slide. So this is slightly out of date in that we had initially targeted for the full study 50 relapses and in early stage seminoma and 100 relapses in non-seminoma. So we okay, whatever.
I'm not controlling it. It has a mind of its own. I'm not touching the thing. So
Okay,
could the
well,
central controls help us move back, please?
Okay, quickly then, we're the interim analysis is going to be at 40 relapses of early stage seminoma and 40 relapses of early stage non-seminoma. We now have, I think, 36 and 37. So we're on the cusp of launching the interim analysis. Hopefully we'll get going before the end of the year. Overall accrual is targeted for 956. I think we are now over 820. So we're accruing about 20 some patients per month now that the high-risk cohort is closed. So we anticipate probably early 24, we will be done with the accrual, and hopefully we will have a successful interim analysis and probably be able to move on to analysis of the primary endpoint by early or mid 2024. Next slide. Okay, just a little quick history, because as outlined, this has been very rapidly accruing. It started in the middle of COVID, as you see, and despite that, and despite concerns that it's an uncommon tumor, we have had extremely brisk accrual. People, particularly centers who enrolled more than just a few patients, quickly learned how to do it and have become quite facile at putting patients on study. And it's been very gratifying to see the response from patients, investigators, and to get this moving along as quickly as it has. Next slide. So this is a success for a lot of reasons. There haven't been many cooperative group trials in testis cancer since the 1990s. This was specifically designed to reflect real world care. So it's open through NCORE, and I will say proudly that the largest accruer is not what you would expect, an Indiana University or British Columbia or Toronto or USC. It's the Kaiser system of Northern and Southern California, who have have accrued over 100 patients through their networks. The design of the study was to reduce the workload on the accruing centers. The trial does not stipulate any interventions. So it reflects real world choices of care. And so there's no SAEs, there's no response assessments, and it's very, very easy to enroll patients. There's a high level of participation from the patients, even knowing that they're not going to particularly benefit from that, but their blood is drawn at the time they would have regular blood draws. So it really is a very low patient burden study. This really has captured the imagination of the germ cell tumor academic community, and there are now mirrored studies that we have helped coordinate in Australia, Italy, Scandinavia, and Britain. So this really is a global study, and fortunately, we're going to be able to lead the way with this, hopefully shortly, and wring the full value out of this study with the secondary use aspects that will be supported by the R37 mechanism, and we're starting that planning now for the logical extension of the R01 that Dr. Nappy was able to be awarded. Next. So here are a list of the participants and support. The Canadian and Prostate Cancer and Hope Foundation, the Canadian Clinical Trials Group have all supported Dr. Nappy's research, and we're greatly appreciative. Thank you. Any questions?
Yeah, are there any questions either online or in the room? We're running a little bit tight on time, so we'll ask for burning questions at this point.
I have one very quick question. Craig, maybe this is Manu, you might have mentioned it. So besides the liquid biopsies, you are also banking tissue from potential relapsed patients?
No, we are banking, the Buffy code is being banked, so we can do DNA, and but this does not, no testis tissue or tissue from metastatic sites is being banked, no.
Thank you.
Okay, thanks very much.
Okay.
All
Bye.
right, now, thank you. Moving on to our next presenter, Dr. Kathy Crew, will be presenting her cluster randomized controlled trial of patient and provider decision support to increase chemo prevention uptake in high-risk women.
This advance. All right. So just to refresh, this is the schema for S1904, which is a cluster randomized controlled trial of web-based decision support to increase chemo prevention informed choice among women who are at high risk for breast cancer. So it's a multi-level intervention. There's real risk for high-risk women and BNAV for the healthcare providers that care for these women. And which is the intervention arm versus standard educational materials. And our goal is to enroll 415 women who have a history of atypical hyperplasia or lobular carcinoma in situ, which is a important high-risk population to target for chemo prevention with either SERMs or AIs, and then also enroll 200 healthcare providers. As was mentioned, our primary endpoint is a patient-reported outcome, which is chemo prevention informed choice at 6 months. But secondarily, we'll look at other patient-reported outcomes as well as actual chemo prevention usage and adherence, reasons for discontinuation among women who start these medications. And this is supported by R01 funding. So the first aim is actually to conduct the clinical trial, and then we have a second aim which is a more implementation science aim, sort of apropos of what we discussed during the CCD committee meeting. So even if we find that our web-based intervention does not increase our primary endpoint, we'll be able to assess barriers and facilitators to see what worked and what didn't work. So the R01 funding started in December 2018. The trial got activated, took a little while, but eventually got activated in September 2020. And here we are at accrual. So we're more than 3/4 of the way to enrolling our target accrual, which is 415 patients. We've randomized, we have all of the sites that our goal was to enroll 26 sites total. This is a limited institution study. There have been 3 sites that have dropped out and didn't enroll any patients, all in the control arm. And so currently we have 14 intervention sites and 11 control sites. So rather than get one more extra site, we're just going to try to enroll more patients in the sites that already have the trial open. We've completed accrual of our target of 200 providers. We're actually up to 205 because we got a few replacement providers for the sites that dropped out. And in terms of the accrual, so for these cluster randomized trials, the ideal would be to have equal patient accrual across all of the sites, but we know practically that's not possible. Initially, we had, so on average, there should be about 16 patients per site, and most of the sites are at that, have enrolled at least that target. However, there are some sites that have accrued more. Previously, we had a cap of 32 patients, but we decided to remove that cap. So a few of the sites who are already at the cusp of 30 or more patients will be able to accrue more. And our goal, it's been fluctuating in terms of monthly accrual, but if we can reach our target accrual of like 10 to 12 patients per month, then we should be able to complete patient accrual by early summer of 2024. In terms of our implementation aim, we've already completed our pre-implementation interviews of 25 providers from the intervention arm. And we're more than halfway through, or about halfway through, patient enrollment of their mid-implementation interviews. And just this fall, we started doing mid-implementation interviews of providers. But since we put in the IRB modification to start conducting those mid-implementation interviews, there's another 8 or 9 providers that are in the wings. So I think we've got, with our monthly calls with all of the sites, I think we have good engagement of both the patients and providers in this trial. So in terms of our milestones, like I said, we hope to complete patient accrual by around June of 2024, and then complete 6-month follow-up by the end of 2024, which will fall within our grant deadline with our no-cost extension. In the next 6 months, we hope to finish all of the patient and provider mid-implementation interviews, and then also have time to analyze that data. We did presented an abstract at the San Antonio Breast Cancer Symposium, an ongoing trials in progress poster. And we have 2 manuscripts in preparation. One is the study protocol paper, and then a paper with baseline surveys and pre-implementation interviews of the providers. And then in terms of additional grant funding, we did get awarded, Rita Kukofka is the co-study chair for this trial. And last year she received R21 funding to use for this project, looking at combining electronic health record and patient-generated health data for breast cancer risk assessment. So our Real Risk app actually communicates with the patient portal, at least for sites that use Epic as their EHR. And so patients are able, when they sign up to Real Risk and then put in their portal credentials, there's something called FHIR, Fast Healthcare Interoperability Resources API that allows connection of our app to the patient EHR. And so this didn't require any sort of build at any of the sites. There are these Epic apps that are available that can increase this interoperability with existing EHR. So it didn't really require any EHR build on the part of the sites. So that study is ongoing. And then last year, we applied for this UG1 administrative supplement to support cancer disparity collaborative research that we recently found out just got funded. So very briefly about the study, because it's apropos of our talk, the talk that was given during the beginning of the session. So we have preliminary data looking at statin uptake among women who are at high risk for atherosclerotic cardiovascular disease. So there is this risk calculator, ASCVD risk calculator from the American College of Cardiologists and the American Heart Association, which calculates risk of cardiovascular events such as heart attack and stroke based upon age, race, sex, smoking status, and I think systolic blood pressure, LDL or total and HDL cholesterol, as well as use of antihypertensives and diabetes. And so we can, in addition to collecting data on breast cancer risk factors, we can also look at other comorbidities and risk of cardiovascular disease, which is also common in the general population. And so we looked at a high-risk population at Columbia. Again, these are women with atypia or LCIS, and also collected risk factor data from their EHR to calculate their ASCVD risk. Virtually all of these women met high-risk criteria for breast cancer chemoprevention, and about 30% of them were also at increased risk for ASCVD if their 10-year risk cardiovascular events was 7.5% or higher, which made them eligible for statins. And what we found in this population of women who are at high risk for both conditions, that statin uptake was about 58%, which is what we see in the general population as well, somewhere in the 50 to 60% range, whereas chemoprevention uptake was only about 23%, even though on average, this population of women was at higher risk for breast cancer compared to heart disease. So this was sort of the impetus for the UG1 administrative supplement, where we're actually working on so that ASCVD risk calculator is publicly available. So we're going to try to build that into our Real Risk app, in addition to the Gale model and the BCSC model, which is already in the app. And then we'll use that same FHIR API to extract discrete data for cardiovascular disease risk assessment. So if we can juxtapose breast cancer risk with their risk of cardiovascular events and look at statin uptake as opposed to chemoprevention uptake, could that juxtaposition, enhance, at least raise awareness about the preventative effects of anti-estrogen therapy? And then for the second aim, we'll do a pilot study in 55 high-risk women to see how our FHIR Enhanced Real Risk app improves certain patient-reported outcomes, such as patient activation, accurate risk perceptions, and also usability. So I'll stop there and see if anyone has any questions.
Thank you, Kathy. Thank you very much. Any questions for Kathy? Nothing online either. I think the accrual is really great. Another success story.
And congrats on the additional funding as well. That's a big kudos to answer some important questions. Okay, so next we're just going to have an oral update on SO820. This is Jason Zell's study. The accrual was completed in June, and so we're not going to have a formal presentation today. Hopefully the next time we hear from Jason, he'll have some results from that trial to present. There's still patients on study, but accrual is completed. Jason's not here in person today, but we want to congratulate him for all the efforts he did to get people on that study. So we're grateful for that.
When's the analysis?
I'm not quite sure when that is. It might be sometime in 2024, but we can get back to you about that. Yeah. And the last patient was enrolled in June of 2023. Yeah. Okay, so next we're going to hear an update from Dr. McGinnis on a blinded reference set for multi-cancer early detection blood tests, and she'll come up here to the podium. So if you could bring up the next presentation, please. If we advance the slides, will it bring up the next presentation?
Okay. Okay, so in the interest of time, I'll be brief. I'm just going to give an update on this Alliance trial. As mentioned, it's a blinded reference set for multi-cancer early detection blood tests, for which I'm the SWOG champion. So just as a reminder, the study objectives are to provide a blinded reference set of cancer versus non-cancer blood samples that will in the future be used to validate blood-based assays for inclusion in a prospective trial focused on defining the clinical utility of early detection assays, many of which are already commercially available. Secondarily, they'll evaluate the test performance at the time of cancer diagnosis by tumor type, and then evaluate performance at the time of cancer diagnosis by clinical stage. So this study initially had an accrual goal of 2,000 or 1,000 per for cancer and 1,000 for control, but this was recently increased to 2,900, partly to improve the diversity of the patient populations included in this study. And as of last week, when I checked, they were almost at 1,800 out of 2,900. So in this study, cases and controls will be matched by sex and age decade, and then they'll be followed for cancer status 12 months after registration. So there are different categories of eligibility. The first is patients with known cancer that's histologically confirmed, with specific tumor sites that are pretty comprehensive, which I'll show you briefly in a second. That importantly, these are patients who have never received prior treatment. That includes surgical management of their cancer. So it's really right after the time of diagnosis that blood samples are being collected. Participants should be between 40 and 75, have no prior history of in situ or invasive cancer other than non-melanoma skin cancer, no prior organ transplant, and have to read or comprehend English or Spanish. And as you can see here, the eligible tumor sites are pretty broad, really encompassing the vast majority of solid tumors and liquid tumors as well. The second category is patients with a high suspicion of cancer. This includes patients who have ovarian, pancreas, kidney, or melanoma. The reason they call it high suspicion is often these patients, because of the invasive nature of biopsies, actually go straight to surgery. And so this is based upon clinical and radiographic high suspicion. They had to be planned for surgical resection within 28 days of the study. And this does require essential review of documentation for this high suspicion of one of these cancers. And then the same criteria in terms of age and prior history are also relevant to this cohort. The last time I spoke, I think patients without cancer, so our unaffected population, was close to accrual. With the larger sample size, we've now opened this up again. And so basically these are patients without known history of cancer or suspected cancer, again, in the same age group. And they'll be matched, as I mentioned, by age and sex. And in terms of the study schedule, it's actually pretty minimal for participants and sites. So basically, after patients are found to be eligible and consented, they have mandatory blood samples collected. There's an option for a tissue sample, and they complete a demographic and health questionnaire. And then at 12 months after registration, there's follow-up for their cancer status, which is mandatory. There used to be an option for blood samples also being drawn at 12 months. This has been removed with subsequent amendments. And I guess that's it. Any questions, I guess? I don't know if we have time. No.
Yeah, I'm not sure we have time for
Yeah.
questions, but you could talk with Dr. McGinnis later.
All right, so I'll give an update on the next study that we are champion of. It's the ECOG-ACRIN study 1151, the MISS trial that is comparing mammograms. This is going to be without slides, mammograms versus tomosynthesis. Out of planned 129,000 patients, 89,000, so close to 90,000 were already recruited. They are right on track and have not reported any issues with accrual. And of course, no analysis is being done at this time.
So our next presenter is also virtual. Dr. Deirdre Hill is going to give us an update on the National Myelodysplastic Syndrome Study.
Thank you for an opportunity to present an update of progress on this study. The Myelodysplastic Syndromes, or MDS Natural History Study, is an observational cohort. It was designed to recruit approximately 2,000 participants with MDS or myeloproliferative disorders to collect patient history and biospecimens and to follow participants for long-term outcomes. The study was also collected to serve as a resource that will allow these data and biospecimens to be utilized by external investigators. The effort is jointly sponsored by NHLBI and NCI. Next slide. Recruitment for this study currently stands at 98% of those projected, or 1,940 cases out of 2,000 total, as you can see depicted here in yellow. There is still time to recruit, but the study will meet that goal of 2,000 participants by January 2024. Next slide. As the study was designed as a resource for external investigators and is now completing enrollment, a web portal has been established, given here, to allow queries regarding data and biospecimen availability. The Study Data Access Committee is now accepting applications, approving proposals. So I encourage all those who are interested in utilizing this rich resource to investigate further at the website. Next slide. In addition, an RFA has been released that will fund one-year pilot projects, and details, application materials are available at the web portal given here. Next slide. Future plans for this study, cohort follow-up. When the study ends in January 2024, 6 months of additional follow-up is planned. And in addition, the study investigators have submitted a request for funding for further follow-up of the cohort. Next slide. The biomarkers that were generated during the study, much of that data will be posted online and available to investigators. So whole genome sequencing data, RNA expression data will be available for request through dbGaP. And in addition, I think one of the strengths of this study is that there are serial samples for follow-up of these patients. And depicted here on the right is the mutation status of TP53 over time, so that investigators can trace the changes in biospecimens with progression towards malignancy. These serial data will also be made available. Next slide. Want to give a huge shout out of thanks to the steering committee for this study, the advisory groups, the investigators who recruited patients, and to the patients who continued to participate. As well, we'd like to express gratitude to NHLBI and NCI for jointly funding the study. Thank you very much.
Thank you, Deirdre. Are there any questions for Dr. Hill? Okay, thank you so much.
Okay, we are moving on now to our next presenter, Dr. Julia McGinnis again for S2311 updates.
Okay. So I'm going to give an update on a previously very extensively discussed study concept that's entitled this. So basically, the goal of this concept was to evaluate 2 lower dose chemoprevention options in postmenopausal women who were considered at high risk for breast cancer because of atypical hyperplasia, lobular carcinoma in situ, or hormone receptor positive ductal carcinoma in situ. And the rationale for this was based upon the desire to find regimens that were tolerable and might have improved uptake in this high-risk population. And so the design was to randomize women who were high risk for the reasons I mentioned, 1-to-1 to low-dose tamoxifen, which was tamoxifen 10 milligrams 3 times a week, which is similar to the 5 milligram dose of tamoxifen that's now included in the ASCO guidelines based upon the BabyTam trial, versus alternate dose exemestane 25 milligrams 3 times a week, with duration of study treatment for 3 years. The primary endpoint would have been persistence with initially prescribed oral endocrine therapy for up to 3 years. So just to go over the primary and secondary endpoints as we had designed it. So the primary endpoint is drawn from the recently activated ASPEN trial in premenopausal women with hormone receptor positive HER2 negative breast cancer, which was persistence with initially prescribed oral adjuvant endocrine or oral endocrine therapy medication for up to 3 years. Which was defined as duration of time from randomization to discontinuation of the initially prescribed endocrine therapy. Really what we were trying to get at here is essentially this is a surrogate for discontinuation rates of these lower dose regimens. And then in terms of secondary and exploratory endpoints, we were really hoping to do a robust PRO analysis of the tolerability and adverse side effects of these regimens, which really hasn't been done by previous studies, and even including in the low-dose tamoxifen study that led it to its inclusion in the ASCO guidelines. So we actually presented this at the NCI steering committee in August, and unfortunately, soon after received the word that it was disapproved. And I'm including here, I think, the summary of the main critiques that we received, and I'll go over some of our responses and future directions in the next slides. So one of the biggest ones that was also apparent in the verbal comments during the review is that there was no quote unquote standard dose arm for comparison, that is a standard of care full dose of either exemestane or tamoxifen. The other was that we had no preliminary efficacy data for alternate dose of tamoxifen. There was also a question of the appropriateness of 2 low-dose arms in patients with DCIS, as well as question of justification of treatment persistence as a clinically meaningful primary endpoint that could change clinical practice and justify the conduct of this trial. So some initial things that we'd actually included in the concept, but perhaps were not felt to be strong enough justification. So in terms of the first, which was no standard dose arm, full dose arm for comparison as a standard of care, really we were hoping in this trial to target women who were really interested in low dose options, who might ordinarily not have considered taking chemoprevention at all. We also argued that low dose tamoxifen actually is now considered an option in and is included in ASCO guidelines. And actually, we even have data from S1904 that about half of the providers enrolled offer low dose tamoxifen to their high risk patients. In terms of the question of efficacy data for alternate dose exemestane, the prelim data, again, that we had used as rationale for the 3 times a week dosing was that this 3 times a week dosing of exemestane in a pre-surgical study among women with stage 0 to 2 hormone receptor positive breast cancer showed similar reduction in serum estradiol compared to the daily dose, which really reflects the mechanism of action of exemestane and aromatase inhibitors. And also there's evidence that change in serum estradiol does correlate with breast cancer risk. There also was a study looking at different alternate doses of letrozole over a longer time period, 6 months, that showed similar data. While we don't have efficacy data in terms of breast cancer incidence, we felt that this justified the dose chosen. The other question was whether or not we should really include patients with DCIS in a trial evaluating 2 low-dose arms, given the higher risk of a subsequent invasive breast cancer in these populations. Again, some of these women actually would otherwise not consider taking chemo prevention, but one possible idea is to, moving forward, consider targeting postmenopausal women with lower risk DCIS who could be targeted for a trial such as this. And then in terms of the justification of the primary endpoint, we felt that it was a clinically meaningful primary endpoint because, again, this is a prevention trial. It allowed for us to have, smaller sample sizes and would be required for a quote unquote more definitive trial using breast cancer incidence as the primary endpoint. But I think that was the biggest critique is I think there was some concern over lack of data with these regimens, the lower dose regimens for breast cancer incidence. So in terms of our next steps, so we've actually had discussions already with Alliance Prevention leadership to discuss potential collaborations, specifically, regarding the potential for designing a trial with breast cancer incidence as the endpoint if there is ongoing concern regarding the lack of efficacy data in terms of breast cancer risk reduction of these of the lower dose exemestane. The other possibility, even if we don't end up having a trial within SWOG, is that this could lead to collaboration on more translational or other PRO projects, things like that, where we could have sub-studies within a larger trial with an endpoint such as breast cancer incidence that would still have us have a footprint from SWOG in a larger study, potentially run through another cooperative group. So that was my last one. So we'll take any questions or comments if there's time.
Thank you, Julia. Any questions, comments, suggestions?
Right now, I can't remember exactly what it is, but you know what it for early the concept. I don't know, and I think it involves
Yeah.
I don't know, that would be
Yeah, no, thank you. We had heard about the Gen-C's concept and recent funding as part of this. So I think that'll be part of the discussion. We have a meeting next month with Alliance leadership to discuss all of these different options. I think we agreed, and that's why we initially had not used breast cancer incidence as the endpoint. So we'll have to see what comes out of a potential collaboration and ongoing discussions. I have to remember actually who was on the list. Yeah, we'll take a look.
I think there is not. They had recommended that we meet, so we are doing it, but nobody had volunteered. If needed, we would be happy to. Yeah. Right.
Yeah.
We'll think about it.
Yeah, sounds good.
I still like your initial primary endpoint because I think it has so much preventive value for treatment persistence or, keeping on a medication, as well as potentially healthcare cost reductions. Anything in prevention, if we can prevent, diagnosis and treatment, all the better. So I'm hoping that you don't have to give up on that endpoint. I still really think it's a very important endpoint.
So, this is a hot topic, and obviously Andrea DeTensi did the initial baby TAM trial and had proposed this, essentially the same exact trial, for which they got BCRF funding. So before Julia even presented it to steering committee, we'd already been in communication with him, as well as Terry King, who's another PI on that trial. And I think they have the same exact endpoint of like a tolerability endpoint. So I think we'll still be able to build in some of the translational studies, especially a lot of the breast imaging studies that Julia's been working on. So I think there's multiple things going on in multiple fronts, but I think collaborating with these other investigators will help us to get these trials done more efficiently.
So if no further questions, I'll give it back to you guys.
All right. Thank you so much. Thank you for your, endless hard work on this.
Okay, so our next study on the list is S2405, Dr. Connolly study, and that is one that is on hold for a little bit. So we're not going to have an oral update on that one today. And then I think our next one that Julie is also leading, are we going to have an oral update on that? Yeah. Okay. Okay, so I'll turn it back over to Bonnie.
All right, so looks like we have, several projects we are working on and waiting on some updates. This was it for today. So any final comments, suggestions before we do the closing? We have 5 or 6 more minutes left before we have to leave the room, and the plenary reception will start. And while you're thinking of some maybe thoughts, please feel free to email them to our committee members, to us, me and Marian, to Kathy. We, as we always stress, want to expand our portfolio for other cancer sites that currently we don't have any studies for. So please, think about that. And if you have any, especially early career investigators within your group or yourselves, of course, we are not limited to early career investigators, but we would love to give them opportunities to partner with mid and advanced career senior investigators. So with this, I think then looks like no questions. We can close the session. Thank you for everyone who's online and who's here, and enjoy the rest of the SWOG meeting. Thank you.